Welcome. We have Ann Porretto-Loekhre, who is a presenter at the Virtual Hand Therapy and Surgery Summit. Ann, thank you so much for joining me in this interview today so that our viewers can learn more about you.
Well, thank you so much for having me. I'm so excited to be part of this conference. I think if there is any positives that have come from COVID is the opportunity now to connect with therapists and surgeons from all over the world. And I don't know that that would have happened at the fast timeline that it did because of COVID. So thank you again for having me, Robyn. I'm excited to be here. A little bit about myself. I'm a physical therapist and a certified hand therapist. I graduated back in 1994 with a bachelor's degree, which was that was what everybody did then. And then now everything's a master's and a doctorate. But I graduated, and I remember when I was in school, there was a hand therapist that came and she talked to us. And I think I was like a junior in college then. And she was a physical therapist and practicing in a hand clinic. And I was like, wow, that is so cool. That is what I want to do someday. And so that kind of got me started like, ooh, that would be so fun to treat hand patients. And we had an amazing kinesiology professor that taught at the university where I went. And he really loved the biomechanics of the hand. So I kind of fell in love with that in school. When I got out, I did some hand therapy for about a year. Then I got married and my husband was in the Navy, so that we traveled all over. And when we finally kind of settled down, I got a job at a large hand center, and I've been there over 20 years. And it's just been amazing. I love being in the hand therapy profession because I love that close relationship that the therapists have with the physicians, that we're all working toward the same goal. How I got involved in manual therapy is when I think this was like 2002. One of my coworkers said, "Hey, Ann, there's this really great course you should take in Minneapolis." It was on the wrist, and it was a course that was offered by the International Academy of Orthopedic Medicine, which is a manual therapy group. They are a Syriacs-based group, so based on the work of Dr. James Syriacs, that really emphasizes the systematic approach to evaluating your patient. And then, so we've got that piece, and then we have the manual therapy piece of the intervention. And I went to that course, and I fell in love. I'm like, oh my gosh, it just made sense. And the course, as it was set up, was not set up for hand therapists, but for general practitioners, general PTs, basically. And there was another therapist who was attending the courses at the same time down in Texas. Her name is Mirka Normand, and she's an OT, and I was a PT. And we came together and we decided that this was good material, but this needed to be tailored to the hand therapist. So Mirka and I spent 8 years putting the six courses for this, what we called the Hand and Upper Extremity Track, on the wrist, on the elbow, shoulder, on the thoracic outlet area, and on the fingers and the hand. And it was quite a journey because she had 2 boys, I had a daughter, we had a lot of stuff. We both worked full time, but it was a great journey for us to put these together, and now maintaining with updated research, because you get a chance to really, watch what's new in the literature. Do we need to change what we're doing, or is what we're doing still in line with what the current literature states? So I love having that systematic approach as part of my treatment regime. And I love teaching that, especially to not only to new clinicians, but to seasoned clinicians. It's just a different way to look at your patient. It helps you to be more efficient. And I think that's what I've loved most about using that manual therapy approach. It's the problem solving that really helps to refine what is your issue, what's your impairment, and then what are the ways you can treat it. There are many different ways to treat it, but if you don't know what the impairment is, you can be spinning your wheels and wasting therapy visits. And we don't want to waste our time or our patient's time. We want to get to the root of the problem. And that's where I think using that systematic approach. And you'll see this in the lectures that I'll be giving with the conference. With the forearm rotation limitations, we see that so commonly after distal radius fractures. I mean, how many times do you have patients that come in after a distal radius fracture, you ask them to bring their palm up, and then they do one of these numbers, right? Their shoulder, they're coming over, and you ask them to hold still and they can't move. And what we find out when we're going through that systematic approach is that it's not uncommon that we have issues at the distal radial ulnar joint. We can have tears of the TFCC, we can have malalignments that can cause limits, but also looking up the chain, we can have issues at the proximal radial ulnar joint just because of the development of the stiffness whenever the patient has a fall or the trauma. So going through and systematically looking at, is there a malalignment at the distal radial ulnar joint? Is there stiffness at the proximal radial ulnar joint? And helping to figure that out, and then what to do to treat it. Because what we find as time goes on is you don't have to be aggressive, especially like people that are really trying to forcefully, and patients do that all the time, and like, no, you don't have to be aggressive. Once you figure out what the problem is, for example, if your distal ulna is more prominent and you can realign that and their forearm rotation improves, that's not something to mobilize, that's something to stabilize and realign. So that's where some of the other prefabricated or custom braces can come into play. So we can be gentle and still get what we need to do without being aggressive. And I think that's especially with the forearm, that's one thing I see often. And when you go through and therapists learn about this, they're like, oh my gosh, I just have to mobilize the proximal radial ulnar joint, and maybe they need a wrist widget, or maybe they need an ulnar compression strap, and that did the trick. I'm like, yeah, that's it. So it's fun. It makes seeing patients fun again. Yeah. And I think for me, teaching courses has helped keep me rejuvenated and excited, having been in the profession now for 27 years, almost 28 years. So my second lecture goes through with the elbow, and elbow stiffness, I think, is a challenge. It's a challenge for a lot of therapists, because besides passive stretching, you feel like, what do you have to offer? And in addition, there are static progressive splinting options, but there's also some manual techniques that you can use. And we go through that in addressing with the stiffness of the elbow. We find out that we can only actually do a tractioning technique to the humeral ulnar joint. So we're going to go through those techniques in the lecture with a lot of videos, which will be neat to see, so you can practice that. And then also too, addressing as far as with the proximal radial ulnar joint. So that'll be kind of a nice carryover from the forearm rotation limitation lecture. My third lecture is going to be going through as far as with the shoulder. So a lot of traditional hand therapists, they don't treat anything above the elbow. So it's kind of scary when your patient comes in and says, I'm having trouble reaching behind my back, or, I can't reach up to wash my hair. And you're like, oh no. And then that instills fear. And I think it's hard for hand therapists that traditionally treat the distal extremity, because they're so good at it. I think that it makes it even more challenging for them to think about things up here when they've got the tools. It's the same type of thing. It's just a matter of just guiding in the right direction. And that lecture really covers like the three big things you'll see with shoulder problems when you have a distal hand injury or distal elbow issue. So we discuss the first one we discuss is the frozen shoulder. And again, sadly, not uncommon. That is a common occurrence that can happen. But what do you do with it? There's two types of frozen shoulders, and we find the one that we see in the hand clinic is more of that secondary adhesive capsulitis. Comes on from a trauma, patient stiffens up, and we see that what we traditionally call a capsular pattern. So that predictable limit of motion when the capsule has undergone synovitis and starts to tighten up. So what can we do about that? So we go through in that lecture some of the things that you can do in the hand clinic to help start to figure out, what can I do for my patient now? And if that is enough and that resolves it, great. And if it doesn't, when do I need to refer my patient to someone else? The second topic we talk about in that lecture, which is one that I think is more nebulous, is we talk about thoracic outlet syndrome. And, we think about those patients we see with carpal tunnel and cubital tunnel, and maybe they've had a carpal tunnel release or an in situ ulnar nerve transposition. And then they come back to you 3 months later with the same symptoms. And you're like, what's going on? So we find out a lot about what's going on up here. So what we see with thoracic outlet, and I think too, this is the hard piece because there's not some nice, good objective measures. It doesn't always tell us when you have what we call disputed neurogenic thoracic outlet. You diagnose it by a clinical exam and history. And so that's why there's a lot of discrepancy with physicians on the diagnosis. You'll have some physicians say, oh, it's overdiagnosed. You'll have others that say, oh, it's completely underdiagnosed. So it's good because as hand therapists, we have the luxury of seeing our patients on a frequent basis. So we can figure out with their history, well, are they having more of their symptoms when their arm is overhead, or are they having more of their symptoms at night? And we can do some clinical tests to figure that out, and we can get them started to help open things up, get that blood flowing so that we don't have that tension on the nerve, and that can help things downstream. And then our third piece that we talk about in the shoulder lecture is about shoulder impingement, a very common thing, also known as subacromial pain syndrome. So what are the signs and what are the symptoms, and what are some simple tests that we can look for as hand therapists to identify, hey, this is what I think is going on. Let's give them some things that we can do in the hand clinic itself. And if that's not enough, when do we refer that patient? So we go through impingement, talking more about external impingement, because that's what we see more commonly with those patients with a painful arc. And then we also talk about what are some things you're listening for if someone has a cuff tear. We know, unfortunately, as we age, the cuff tends to tear more easily. And we see, especially with our older population, 60, 70 years old, when they have a fall, they can injure their cuff. And what are some things that we can do in the clinic to evaluate that? So I hope that the information is helpful. It's going to be wonderful for you to watch this, practice it, and then use it in the clinic. I'm a clinician. I see patients every week. I use these techniques all the time. And I think it's very fun when you can take some of these things and be like, hey, I'm going to try this. Oh my gosh, I found this patient with this chronic pain in their wrist. I reproduced it with their thoracic outlet test. Now I know where I need to go. So it makes it fun and exciting. So thank you so much.
Oh, that's incredible. And it's exactly what we need as therapists, because what you've done is you've covered from the neck to the fingertip, and you've enabled us to look at everything holistically, look at our patient as one whole unit, where, structures can influence each other. And that often is very difficult for a newly qualified therapist or somebody who's just starting out in hand therapy. They have passed their CHT, they've done all of that studying, they know their anatomy, they know everything, but now that patient presents in their own unique way. And it's
scary. It's scary. You think I know all these tests, I know all these things. And then the patient's sitting there and maybe you only have a half an hour and you're like, yes, all right, what do I need to do that we don't need to do every test on every person?
Yeah, and for me, it's about starting treatment in that session. You don't just want to be testing. So, if you can look at that person and be that investigator and go through that checklist in your mind and have a sense and a feeling for that whole upper limb, and then be able to do one little thing in that session that relieves their pain, gives them that range of motion, gives them that function, it's going to encourage them to come back.
Right, absolutely. And like you said, they have buy-in. They're like, oh, and they appreciate that someone listens to go through the whole thing and doesn't just take one little thing and say, oh, it's this, and then move on. So yeah, exactly.
Absolutely. And I'm also finding as well, when a patient has a distal radius fracture, if they're going to fall on their outstretched hand and you have a look at that x-ray and it is quite a fracture at that distal radius, that injury is ricocheted to the elbow and even to the shoulder. And very often I start my treatment at the shoulder and the elbow, and then you gain that range in the wrist because it's often neglected. It could be, malalignment of, the radial head, or there could be some kind of nerve compression that's begun. And it's so important for therapists to have those skills.
Absolutely. And I think too, when you think about not everyone moves exactly biomechanically in a good way, and then you add trauma to that, and they're in a big bulky dressing, and you can just see how something that might have been just on the edge now has started a bigger problem.
Yes, no, that's amazing. And as you say, so that therapy can be fun, because when you feel that you can do it, oh, you can't wait for your next patient to walk through the door.
It's empowering. It's like, hey, I made a difference in someone's life today. That's what I think is wonderful about being in healthcare and being a hand therapist, because you develop that relationship with patients. The longer I practice, the more I appreciate you get to affect someone in a positive manner in all walks of their life. And that's something that not everyone can say in their profession. So I feel like we're doing something very useful, making a difference, a profound difference in that patient's life, and maybe those around them, their families, etc. So
let's talk a little bit about your journey from being a clinician to an educator. It wasn't quite a long time, 8 years to put the courses together is amazing. Have you, these have been in-person courses, correct?
Right, yes. They are in-person courses. We do have some webinars and things, but for the most part, yeah, they are in-person courses.
And then do you have any plans to make your courses virtual and online?
Probably. I have been spending a lot of my spare time videoing. I spent a weekend last summer just videoing techniques, and that's a lot of those that you'll see in the lectures. But I want to have it so that it can be lasting and it can reach people all over, not just if you can physically be there in person. But how I started in education, it was kind of by accident. I really enjoyed like doing little in-services for the staff whenever I would go to a course. But this was back in 2004, and there's a big hand conference in Milwaukee that they have every year. Milwaukee is about 2 hours from us, and they had called our clinic, and they had said, "Hey, we really like to have speakers from Wisconsin it's called the Wisconsin Hand Experience. That's the conference." And anyway, they had said, "Is there anybody that would want to speak?" And my manager at the time, she's like, I wonder if Ann would want to do it, because she really likes doing that stuff. So she asked me if I wanted to do it. And I was like, me? Really? Oh, okay. So I did a course, and what I treat a lot of is thoracic outlet. And so I did a Saturday workshop, like a 5-hour thing on thoracic outlet. And I was like, and it was a lot of work to put together, but it was fun. It was fun to shoot the photos and to get all the research together. I'm like, that was great. And I think then I was hooked. And so from then on, my poor husband and family, I used to have stacks of journal articles. Now it's all on the computer. But yeah, they got used to me having by the kitchen table a big stack of stuff that I always read. But it's really, really fun. It's fun to connect with therapists from different walks of life and have them come up and say, "Oh my gosh, I have a patient with this same thing. I can't wait to try it next week," and it's neat. It's very refreshing and fun.
And do you mentor therapists? I mean, I know that you're teaching them in their class setting, but do you do one-on-one mentoring?
I don't actually, well, I do with therapists emailing me questions and things. I answer it and I'll talk to them on the phone and stuff, but I don't actually do formal one-on-one mentoring outside of my job. Right now, I do a lot of mentoring with the people I work with, but I haven't gone into that realm, honestly, because I don't have a lot of time. I have a 11-year-old girl. I work full time, and I've got to spend time with my family too.
It's all about balance.
It is, yeah.
Yeah, and fitting it all in. But, I do believe that by sharing your knowledge and by running your courses, you're impacting on so many lives, because that therapist that goes back into their environment in their hospital is going to teach their colleagues around them. So it really just, has a domino effect, which is what we need, because there is only so much time and also so much money to attend all the courses.
Right. True. That's true. And, I like to teach from my experience too, that things that I found that have really been helpful, those are the things I want to share. Sometimes you go to a course, you learn all these different things and you're like, okay, where do I start? And this is where Mirka and Normand and I, we really felt that we wanted to be concise, and we really wanted to, we know that it's valuable time. It's time away from your family when therapists are attending courses, whether it's in person or online. And we want to get the most clinically relevant, valuable information to the therapists. And that was really what we were focusing on as we were putting these together.
And that's my focus for the summit, which is just exactly that, being able to provide something collectively that therapists can zoom in on and just learn those few little skills and then apply them. So by sharing your knowledge with us in this way, with your 3 very generous, practically based courses, all I can say is that thank you, because that is exactly what we need to be able to just make those small changes in our practice, and then rather attend one of your courses and learn more and be able to dive in deeper, hopefully online, so I can attend.
Right. Yes. Well, and I think, like I said, I think that's coming in the future. I know, I don't know if you have felt this, Robyn, but I feel like it's a different skill set to teach online than it is in person. You really, and it's getting better,
Yeah.
Probably my first webinar was, but yeah, so I'm getting more accustomed to how to relay the information through the screen versus when you're in class, you could just, hey, you put your hand here, you do this. And so that's gotten better over the last 2 years. So yeah.
Well, that was the journey I kind of embarked on with the casting motion to mobilize stiffness course, because that is very practical. And you have to feel it on that person's hand. You have to feel stiffness. But I did what you're doing. I took lots of videos, and I still do that whenever I have a patient. My patients sign a global consent form, which says that they will be videoed and it will be used for medical science. And they're always too happy as well to participate. But as you go through your day, you collect these moments which you often never get again, and then you can use that virtually, and it's actually then easier because we can insert them into our presentations, and it feels that therapist has just stepped into your treatment room to watch you.
Right. True.
We've just had to get our heads around it, but once you do it, it really is, and also becomes a little bit addictive, right? So often I just oh yes, yeah. I've got to share this, I'm going to share that.
Oh, I got to take this picture, yeah. Or get this quick video. Yes.
Exactly. Well, thank you again. And I can't wait to see all the presentations, and we look forward to hopefully meeting you in person someday.
And thank you so much for putting this together. I'm really excited to be a part of it and to be able to watch all the amazing speakers. So thank you.
Okay, thank you. Bye.
Bye-bye.